Hey everyone, and welcome! If you're gearing up for the NCLEX, you already know that fluids and electrolytes can be a real beast. Seriously, it's one of those topics that trips up so many students, but it really doesn't have to. We're going to break it all down into a super simple system you can actually remember.
You ever feel like your head is just spinning trying to connect all the dots? You see the patient's fluid status, then you look at their labs, then you have to figure out their ABGs. It's a lot, I know. But that's a classic NCLEX challenge, and I'm going to show you a straightforward way to nail it every single time.
Okay, so here's our game plan. First, we're going to crack the code with a simple framework. Then, we'll walk through our 3 key steps, looking at the fluid, analyzing the electrolytes, and then interpreting that acid-base balance. And we'll wrap up with the most important part, what you do first.
Now listen up, because this is probably the most important thing you'll hear today. Acing this section on the NCLEX isn't about memorizing a million different facts. Nope. It's about having a system, a reliable framework that you can apply to any scenario they throw at you. I love this visual because it explains homeostasis perfectly. Just think of the body like a seesaw. On one side, you have the lungs, and they're managing CO2. On the other side, you've got the kidneys, and they're managing bicarbonate, or HCO3. They're constantly working together, making tiny adjustments to keep the body's pH perfectly balanced right around 7.4. It's a beautiful dance, really.
So this is it. This is our framework. It's a simple 3-step process. First, we look at the big picture, the fluid status. Is our patient totally overloaded, or are they dry as a bone? Second, we dive into the labs and analyze the electrolytes. What are those numbers telling us? And third, we interpret the ABGs to figure out that all-important acid-base balance. Let's jump right into step 1.
So, for step 1, before you even glance at a lab value, I want you to ask yourself this one fundamental question. Does my patient have too much fluid or not enough? It all starts there.
Step 1. The fluid status.
The NCLEX is going to paint a picture for you with its questions, so you need to look for the clues. For fluid deficit or hypovolemia, you're looking for all those classic signs of dehydration, right? Poor skin turgor, dry mouth, low blood pressure, and a fast, weak pulse. On the flip side, for fluid overload or hypervolemia, you're looking for swelling, those crackles in the lungs, high blood pressure, and those big, bulging neck veins.
So once you've figured out the fluid situation, you get to choose the right tool for the job. If someone's in a fluid deficit, you'll probably reach for an isotonic solution like normal saline to just fill up the tank. If the dehydration is more on a cellular level, a hypotonic solution can actually push fluid into the cells. And then you've got your hypertonic solutions, which are used in really specific dangerous situations like cerebral edema to pull fluid out of those swollen cells.
All right, we've got the fluid status down. Now we can move on to step 2. It's time to look at the lab values. Every single electrolyte tells a story, but for the NCLEX, you got to know the 2 main characters inside and out, sodium and potassium.
And here we are, step 2, electrolytes.
Okay, here's a huge tip. When you think sodium, I want you to immediately think brain. With low sodium, hyponatremia, fluid shifts into the brain cells. They start to swell, and that leads to confusion and even seizures. With high sodium, hypernatremia, the brain cells get dehydrated, causing agitation and that classic intense thirst. Just remember, sodium changes mean neuro changes.
And you know we love a good mnemonic to get us through the NCLEX, right? To remember the signs of high sodium, just think fried salt. That's F, flushed skin, R, restless, I, increased blood pressure, E, edema, D, decreased urine output, skin that's dry, A for agitation, low-grade fever, and T for thirst. It's a really quick way to lock in those symptoms.
All right, let's talk potassium. If sodium is about the brain, potassium is all about the heart and muscles. Now, both low and high potassium can cause muscle weakness, but you have to know the cardiac signs. Low potassium, or hypokalemia, can cause dangerous arrhythmias, and on the ECG, you'll see a flattened T wave. High potassium, hyperkalemia, is even more scary. It can cause a slow heart rate and those classic tall peak T waves you've heard about.
And of course, there's a mnemonic for hyperkalemia too. This one's pretty dramatic, so it's easy to remember. Murder. That's M for muscle weakness, U for urine output dropping way down, R for respiratory distress, D for decreased cardiac contractility, E for those ECG changes, and R for decreased reflexes. It spells out all the danger signs.
Okay, we've done the fluid assessment, we've analyzed the electrolytes, now it's time for the final piece of our analysis, interpreting those arterial blood gases, the ABGs, to really understand the body's pH balance.
Step 3. The acid-base balance.
And we're back to our trusty seesaw. Remember how the lungs control the acid, CO2, and the kidneys control the base, HCO3? Well, what's so cool is that if one system gets out of whack, the other one tries to fix it. That's called compensation. So for example, if the kidneys are failing and the body becomes acidic, the lungs will try to compensate by making you breathe faster to blow off all that extra CO2.
Let's look at the actual values you need to know. A pH below 7.35 means acidosis. Above 7.45 is alkalosis. Easy enough. For bicarb, or HCO3, it's also straightforward. Low is acidic, high is alkaline. But now look at CO2. It's the opposite. A low CO2 means alkalosis, and a high CO2 means acidosis. This is the one that trips everyone up, so burn this into your brain.
But don't worry, there's a super simple way to remember all this. It's the classic mnemonic ROAM. If the pH and the CO2 are moving in opposite directions, it's a respiratory problem. If the pH and the bicarb are moving in an equal direction, it's a metabolic problem. Respiratory, opposite, metabolic, equal. That's it. It's that easy.
So, you've done your three-step analysis. You know the fluid status, the electrolytes, the acid-base balance. You've done all the hard work. But now comes the question the NCLEX loves to ask. What do you do first? It always comes down to patient safety.
And speaking of safety, here is a rule that is 100% non-negotiable. You never deliver IV potassium as a bolus or an IV push. Ever. It's basically a lethal injection. It has to be diluted, and it has to be infused slowly on a pump. This is a massive NCLEX safety point.
So let's talk priorities. For hyperkalemia, you're worried about the heart, so your first action is to get them on a cardiac monitor. For severe hyponatremia, you're worried about the brain, so you initiate seizure precautions immediately. For hypokalemia, you're monitoring the ECG while you replace that potassium slowly. And for hypocalcemia, or low calcium, you're also on seizure precautions and watching for tetany, like muscle spasms and twitching.
Okay, let's wrap this up with a quick challenge, just like you'd see on the exam. A patient's ECG shows tall, peaked T waves. You immediately recognize this as hyperkalemia. So based on everything we just covered, what is your #1 priority action? If you said place the patient on a continuous cardiac monitor, you are absolutely right. With hyperkalemia, protecting the heart is always the top priority.